Hi, everyone. Thank you for joining us in a new episode of our PPH Insights interviews. Today, we have an amazing guest. I am very, very excited in having Dr. Luke Messac here as our guest today. And then I would love to start, Dr. Luke. We always ask our guests, how would you introduce yourself? If you enter into a new room with people you don't know, how would you introduce yourself?
Yeah, thanks so much for having me. Really excited to be here. I guess I would tell them I'm an emergency physician and a historian. I trained in both, and I draw my identity from both things, and I try to bring insights from both into my work.
Amazing. Thank you. Thank you for that. And just for the record, and before we start with the questions, one of my favorite subjects in school was history. So I am really excited to having this conversation and meeting you. Okay, so how did you decided to go into medicine? Like how did that start?
I think I was in college and I had some mentors who I really admired. One of them was Dr. Paul Farmer, really hero of social medicine, tragically died a few years ago. But when I was in college, he was one of my professors. He taught a class called AIDS in the Caribbean to a group of undergraduate freshmen. And we were all, so enthusiastic to be in the class and learned from him how global health could be much more than mere charity or kind of neo-colonial efforts that public health had been in the past, and really what was possible through a kind of solidaristic approach to medicine and public health. Something I've tried to take with me and incorporate into all my work, but he was a real shining example of what a doctor can and should be. And through him, I met so many other people who were doing great and similar work. So I think it was through that community of people engaged in social medicine, global social medicine, that I became interested in medicine.
Thank you. Yeah, and I mean, every single person that is somehow related to healthcare, we obviously know about Dr. Paul Farmer's legacy. So I can imagine how exciting it was to be with him and meeting with him in those classes.
Yeah, he had so many mentees. I mean, it's amazing. Even after he died, you learn of so many ways that he impacted people's lives. And he always said that students were central to his life and his work, and he really did live that out. And so a lot of us felt really special for the relationships we had with him. And I'm just one of many.
Okay, so let's get into what I know most people and our followers will want to know more about: your money or your life, debt collection in American medicine. What was happening in your life when you decided to start writing this book?
Yeah, I started writing it out of a little bit of personal experience. I was not facing medical debts myself, but my patients would bring it up. I work as an emergency physician, and at the time when I started writing this, I was in training in emergency medicine residency in Rhode Island. And I love my hospital. I love the place that I worked. I love the people at my hospital. But I would always hear patients bring up how much will this cost? Can I really afford this? Sometimes even harsher judgments about what we were trying to do to them, make a buck off them, and things like that. And I always tried to assuage patients' concerns and say, you know what, just focus on your health. We'll deal with this. And certainly the hospital will work with you if there's anything you can't afford. And I just left it at that. But that wasn't nearly enough. I was starting to hear stories about patients in other hospitals, Johns Hopkins, other places, who were being sued by their hospital when they couldn't afford their bills. And I really just wanted to make sure that that wasn't happening where I was, that wasn't happening at my hospital. So I went down to my county courthouse and I started looking at records there, and very quickly found out that my hospital was suing patients in the hundreds. And these were low-income patients, women, single mothers, people living on disability, people living on fixed income, people who could not afford these thousands of dollars that the hospital was demanding of them for a single visit. When they asked for lenience, they sometimes got a payment plan that would have them paying back a single visit for 6 or 7 years. If they didn't pay that in full and on time, they would face double-digit interest. If they didn't pay that, then they could have their wages garnished and face other legal trouble. So this was really something I thought was beyond the pale. I did not know that my hospital was doing this, and I couldn't really stomach the idea of going to work every day, trying to treat patients in extremis, knowing that if I got them through, if they were healed and went home, they would then face potential legal trouble for the work I had done. That was something I never thought was part of my remit. So I wrote a piece about it and tried to get it published in some major newspapers. They weren't interested, and I ended up publishing it on a small blog in Rhode Island. It made a stir in that my bosses read it, the CEOs of the hospital read it, and I had to have some meetings. At first, they said they weren't suing patients, that I was wrong. And I thought this was strange because, well, I didn't know all that much about the topic yet, but I did know that they were suing patients because I'd seen the court records. So I showed it to them, and then they eventually relented and said, oh, they were suing patients. They didn't know about it. It was their debt collector. And so that started a whole string of questions. How is this happening? How is it that our hospitals are suing patients and that the C-suite executives don't know about it? I actually believe them that they didn't know. I don't think it's an excuse, but I do believe they didn't know. So that got me interested in trying to tell the story of how we got here. How did we get to a place where so many of our hospitals are really taking punitive legal action against patients and treating them like criminals?
Yeah. Now, something that you just mentioned about this relationship that you had with your patients. I know that you have referred sometimes to this relationship as a sacred relationship. And another thing that you mentioned in the book is how debt and debt collection is driving in a wedge between doctors and patients, and is destroying the patient's trust. And I can completely see that and agree with that. And at the same time, I can imagine and I can see some people out there that could talk about how hospitals too make sure that they are financially stable and that they can go on with their needs to see more patients. What would you tell these people that could disagree with this approach?
Yeah, I'll take the last one first because that's really easy. Hospitals don't need to sue patients. It doesn't help. It doesn't help them. The data on this is pretty convincing. There's a study out of Virginia that showed that of the hospitals that sued patients, the ones that did made about 0.1% of hospital revenue through the practice. The hospital that sued patients the most made 0.2% through the practice. So, most hospitals in a good year will have 5-6% margins. Like they don't need this money to keep them afloat. If you're a struggling hospital, this is not the thing that's going to keep you going. And a lot of the hospitals that are suing patients are not struggling. They're the large academic medical centers or large non-for-profit or for-profit medical centers that carry healthy profit margins or healthy revenues. This is not a necessary thing that hospitals need to do. In terms of the sacredness of our relationship with patients, I guess I'm trying to draw a distinction between the parts of American life, and there are many, where the expectation is that you will seek profit maximization come what may, right? There's so many parts of American life where, capitalism are real supreme, and the expectation is that people will be profit maximizing, rational market actors. Medicine isn't supposed to be that way. And at least doctors aren't supposed to be that way. We take an oath to our patients, and there have been, I quote a lot of statements from medical societies from the 19th century, from the 20th century, stating that our job is not to pursue profit. Our job is to treat patients. We have to make a living in the meantime. And a lot of doctors have worried about that for centuries, sometimes worried about their own debts, even today. Our job is not to maximize profits for ourselves or for whoever we work for. Our job is to treat patients. And so to the extent that our hospitals and our private equity companies or whoever we're working for are pursuing patients to the ends of the earth for debts they can't pay, then we are breaking that bond. We are part of something that is breaking what I think is a sacred trust. This sacredness comes out of an idea from Durkheim, the sociologist from 100 years ago, who basically split the world between the sacred and the profane. The profane is the hurly-burly of everyday life, wheeling and dealing, trying to make the best you can for yourself. But sacred is different. Sacred is something deeper. And involves obligations that don't hold in other parts of life. I think medicine can and should and needs to be in that realm. It doesn't mean it needs to be religious, but it needs to be a part. And we all believe that in that most of the acute care hospitals in the United States are nonprofit entities. They were started by ethnic associations or religious orders or philanthropists, and they do not have shareholders. They forswear profits. They get a tax exemption as a result. And they need to act like they are part of something beyond the market economy, because that's what they're meant to be.
Yeah, no. I totally see that, and I agree with that. It's really interesting how the history of hospitals started like that, and it has been changing across the centuries. Now, you mentioned the oath that we as physicians took when we went to medical school, and Dr. Don Berwick recently has mentioned the idea of hospital admins taking the Hippocratic oath so that they could also hold some kind of same standard as the clinicians. What do you think about this idea of inviting the admin part of the hospital to also take the Hippocratic oath?
Yeah, I mean, perhaps a new and updated oath. Other people have tried to update the Hippocratic oath. The old Hippocratic oath is, tells you never to to participate in an abortion, things like that. So there's different versions of the oath that one could take. Some more updated than others, and some more devoted to the kinds of creed that we're discussing here than others. But yeah, some form of oath I think would be nice for them to take. I mean, that gets to the point that hospital administration for much of the early history of hospitals was, either those religious orders, nuns and monks and priests, or they were physicians and nurses themselves. And that's changed. A lot of nonprofit boards are now made up of financial executives who think in terms of balance sheets and dollars and cents and growth. And those are not our primary aims. Our primary aim as a hospital, as a community of care, shouldn't be to grow at all costs, shouldn't be to make a profit at all costs. It should be to stay open, but that should and doesn't need to involve punitive measures against patients. So yeah, hospital executives should take an oath. They should share at least some of our values, but they probably also shouldn't all be outside of the caring community. They don't all need to be doctors. They don't all need to be nurses. The community should have a large say in how hospitals and how they are run. But the community writ large is usually kept out of that process. We need to do a lot to change the composition of our hospital administration as well.
Now, one of the other quotes that you mentioned in your book that caught my attention was how doctors are divorced from the process of debt collection that happens with our patients. My question will be, do you believe it's part of our responsibility to be informed of that process?
Yeah, I really struggle with this one because I think it's a lot to ask physicians to be up to date on their fields, to be caring professionals in the clinical setting, to have some awareness of what's going on beyond the clinic for our patients and be socially aware and socially involved. And now we're saying you should also be involved or understand the process of billing and debt collection at your hospital. And adding one more responsibility and burden to overworked clinicians is maybe one too many. But I do think there's something to be said for the fact that in the 19th century, doctors were the debt collectors. Doctors were the people primarily involved in collecting their bills. And so they had to make a decision every time some patient couldn't pay. What would they do? Would they sever the relationship? Would they make a payment plan? Would they forgive the debt entirely? What would they do? And that was a fraught relationship, but it was deeply tied up in the relationship between doctor and patient. But now the people calling and writing and suing our patients aren't even the hospital executives. They're hired third-party debt collectors, often people for whom a patient is not a patient. It is just a number on a spreadsheet to be maximized at all costs. And we can't allow that to happen. So we really do have to insist that our hospitals are more humane, that they make to the extent we have a process that can be humane, it should be as humane as possible. The financial assistance that exists that nonprofit hospitals have to offer every patient should be easily accessed and not made impossible to apply for, as it is at many hospitals. Patients who can't pay, shouldn't be run through extraordinary collection actions like reporting their debt to credit bureaus, foreclosing on their homes, placing body attachments that have them arrested for not showing up to court hearings. These are the ways that a state treats violent criminals. It's not the way that doctors should be involved in treating patients.
Yeah, no, I agree with that, and I can see how in your book you mentioned about how all of these extraordinary activities done by the debt collectors are completely out of proportion of what is happening with our patients. Now, there's another thing that you mentioned there that struck a note with me, and I want to ask about. We know that probably the CEOs or the directors of these debt collector agencies have maybe a motive of greed or some other thing of doing this. But there are also the people that make the calls and like the ranks, and they are also like involved sometimes in debt themselves, and they are just like normal people in that sense that are also have struggles. Like, and people could argue maybe, oh, these are villains because they are doing this, but some people could also argue they are doing their jobs. How could we reconcile those two ideas?
Yeah, I have a lot of sympathy for the people on the phone calls. It's grueling and morally painful work that they're doing for little pay. It's the poor collecting for the poor for the benefit of the rich. You know, these jobs don't pay well. They have massive turnover. They're disproportionately, low-income women who are doing this job, and they're being asked to do the impossible to squeeze the last dollar from someone who doesn't have it, from the destitute sick. So I have a lot of sympathy for the folks involved in the day-to-day work of like making those phone calls and trying to pry more money out of patients. I don't have as much sympathy for the captains of the industry. I profile some of them in the book just to show who really is involved in collecting this money. Some of them are former congressmen, some of them are billionaire owners of NBA teams. These are rich and powerful men who certainly don't need the money, but who make it their business to be involved in this trade. And so people who choose it, like those captains of industry, that a little less sympathy for them, perhaps.
Yeah. Now, in your book, you also write down some questions, and I wrote down one of those, and I want to ask you if you have found the answer to this question. So your question was, why should medical professionals permit the ruin of their most vulnerable patients? Why? Why should that happen? Have you found an answer for that?
I suppose it's a bit rhetorical and a challenge more than a question, but I think a lot of it has to do with blindness, that a lot of us don't know what our hospitals are doing or what our private equity company is doing, or if we work for an insurance company, as many of us do, or what the insurance company is doing. I don't think that blindness is justifiable. We need to know what our employers are doing. We used to be kind of an independent profession, a community of professionals that prided ourselves on our ability to do as we wished, to make decisions as we wished. We hung out a shingle and we were our own entities. That's no longer the case. Most physicians, about 3/4 of physicians, are now employed by large corporate entities, large physician groups, large hospitals, private equity companies, insurance companies, all sorts of entities that aren't, democratic or independently owned physician groups. I don't think the past was perfect. Physicians in general have not had great politics on access and equity in the past in the United States, but this is a whole new ballgame. And it's now our responsibility as employees to know what our employers are doing and to push them when they're not doing right. And so we can take a page out of the playbook of other employees in these entities, nurses, food service workers, other unionized employees who have formed unions and used them to push their employers to do right by patients. I think that is an example that we can follow.
And finally, talking about examples, one thing that you also mentioned, and for me, that really resonated with me, because that's what we do in People Power Health. We do organizing and we support clinicians who want to organize. You mentioned that physicians and nurses need to form alliance with patients. How do you imagine this organizing happening?
It can take multiple forms. I mean, I've been working a little bit with the Committee on Interns and Residents, a community of people organizing, residents organizing into unions that has really flourished in the last couple of years at large academic centers around the country. And one of the things they're working on is to make sure that in their negotiations that they push their hospitals to be better protectors of their patients and to not be not be predators against them. I think that's great. Some of the work is to partner with patients when they're doing this pushing themselves. And one of the groups I'm working with is a group called $4, which was started by a former bartender who helps patients apply for financial assistance and doesn't ask them for a dime to do it. It's a real solidaristic exercise. I think a lot of us would learn a lot by being involved in those kinds of efforts, seeing what our patients are going through. How hard is it really to apply for financial assistance? What kind of rigmarole are our hospitals putting them through? How many calls do they have to make? How many forms do they have to send in to get what they're legally entitled to? So that those kind of efforts, I think, are helpful too. But then there's also, large scale efforts, the push for Medicare for all, the push for changes in federal and state policy that really do require, I think, physician and nurses' voices to be much more engaged. And there are groups that are doing that. Physicians for a National Health Program has been pushing for Medicare for all for a long time. There are other groups that are doing the same thing. Increasingly, even medical societies are taking this stance. But we should be involved in that push as well.
Thank you. Now, as we start to get into the last part of our conversation, I would like to ask you three final questions before we wrap up. The first question is, what will be the top 3 things that you will advise to clinicians, to doctors, to nurses to be aware of, to do? What will be those top 3 things that you will advise?
Yeah, I think first is read your hospital's, if you work at a hospital, read the financial assistance policy. Every nonprofit has to have a financial assistance policy. Most for-profits do as well, which states how patients will qualify for financial assistance. It also talks about oftentimes what sorts of extraordinary collection actions the hospital is willing to take, things like garnishing wages and suing patients and things like that. So sometimes you can just learn what your hospital is doing through that. If that doesn't, if that turns up something that you don't like, then I would say, talk to your colleagues, if you have union representation, talk to them and get in touch with your hospital administration. Maybe they don't know that their hospital is doing what they're doing. Maybe they'll change their stance. A lot of hospitals in recent years have, and I can tell you, it feels a lot easier to go to sleep at night knowing that the place you work for isn't suing patients or isn't pursuing them in ways that we wouldn't want them to. There's so much in our healthcare system that's unbearable that you just don't need one more thing. And getting that off of the plate is really nice. And then to the extent you can, get involved in these larger efforts. Look up $4, look up the Debt Collective, look up People Power Out. It sounds like people are already involved in this, but it's really hard to do anything by yourself. Paul used to tell us, if you're going to do anything worth doing, you got to do it together. And so I think that is true. Like, just for sanity's sake, it's going to be hard to keep working at it if you feel like you're doing it alone. But there are so many people who are engaged in this and really excited to make our system better. And I think getting involved in that is just makes life so much more fun.
No, I agree. Okay, next question. If you could go back to any point in history, where would you decide to go and why?
Oh, that's really interesting. So this is I'll keep it related to healthcare because there's so many. But I've always been really fascinated by the moment right after the Second World War, particularly in Europe and in the UK, but also in the colonized territories in Africa that I wrote my dissertation on. But there was a real enthusiasm for social protection and for fairness. And this was the birth of the National Health Service. This was the birth of, created the Great Protections in much of Western Europe and in African polities too. There was a huge enthusiasm for this as well, often frustrated by the colonial powers. But this was a moment when people thought, we've been through so much destruction and pain together. Let's create a society that looks out for one another. And it wasn't perfect, and it had so many people who were left out. But that sentiment, I think, is something that we should recapture. I was hoping that it might be a byproduct of the COVID pandemic, that we would regain some of that. I think there were inklings of it, but not to the extent that I read about and heard about and seen in records from the late 40s. And I'd love to have some of that sentiment back today.
Okay, thank you. And my last question, and I'm gonna adjust it a bit because I usually ask our guest if you could sit down and take a cup of coffee or tea with someone from all the history of the world, who would that be? But I'm gonna change that a bit because of what we talked at the beginning of the interview. If you could sit down with Dr. Paul Farmer and have a conversation, what will you tell him?
What would I tell him? I would tell him thank you. I'm sure you heard that a lot, and tell him I love him. But I would also, tell him that we're gonna keep going. Everyone always asked him how he kept going. How do you keep faith? How do you keep hope in the face of such terrible odds and so much apathy? But he was always a hopeful person, and he said some of it was his disposition, and some of it was that there was no choice but to keep going, even when terrible things happened. And so I would tell him, we're going to keep the work up. He showed us the way, and we're going to keep working. And there are a lot of us. I think that's what I would tell him.
Thank you, Dr. Luke. And before we close the interview, any final comment, any final thought for the people that are going to listen to this interview? Besides, please get this book, because I got the audiobook and it's really good. It's narrated by Dr. Luke, but I'm gonna also take the physical book because I wanted to have it with me. But a final message that you will share with our followers.
Well, thanks so much. Thanks for reading it. Thanks for the interview, and thanks for introducing me to this community. I think I'm always looking for more communities of people invested in this kind of work, and I'm so great to learn from you and other folks in your organization. And yeah, if you want to reach out, feel free. I would be happy to talk with anyone who's interested in this, or if you have any ideas for how we can do better at our institutions and in our organizations, I would love to be involved in that as well. So please do reach out. I'm sure there's a lot of collective wisdom in this group that I could learn from.
All right. Thank you again, Dr. Luke, and thank you everyone for following us in this new episode, and see you all next time.
Thank you.